Conference recording started.
Okay, I'm seeing Sharon from Cottage also on Adobe. Sharon, do we have you on the line as well?
Yes, Boris. I'm here with Scott.
Hi, Boris.
Hi, guys. All right. This is all I'm seeing. So I'm seeing Alhambra and Cottage on the line, and I think we're past a few minutes past noon. So I would recommend that we begin. And I'm going to keep it very informal because we are a small group, and I think we would love to keep this interactive because each of you folks have a number of people in your room listening to this, so it'd be nice to tap everybody's input as we proceed. So today we are talking about engaging patients and families to prevent blood clots and ventilator pneumonia. And as you know, this is track 2, where we're providing learning and exchange for those that would like to engage families as partners in safety and quality of care, contrasted with our track 1, where people are working on forming patient-family advisory councils and other forms of engagement in advisory capacity. And today is our 6th deep dive. We before talked about readmissions, medication error, infections, falls, and other topics. We are recording the webinar just in case other people want to refer to it later on. Because we're so small, all lines are unmuted. Don't put us on hold. And you can mute your own line. I'm sure everybody can do that at this on their phones. You can use the chat function or simply start talking on the phone. And it might be really nice if you guys could just type in the chat box who else is in the room with you. I know Sharon and Scott, you don't have to do that, but it would be nice to capture the names of the nurse managers over in Alhambra. And we are so glad that you guys could join us today over the noon hour to discuss this topic. Karen and Mary, it is something that I thought we could do because we're so small today. We don't usually do the introductions, but it might be kind of nice to do just to ask people their name, organization, role, and then maybe each person can just state what they're hoping to gain out of the webinar today, so that we can be really sure to try to meet those expectations. Would that be okay with you, Karen and Mary?
Oh, sure.
That'd be great.
Awesome. So, Sharon, can we start with you, Sharon and Scott? Could you just tell us and share with Alhambra colleagues your roles, and then what you guys would like to get from the webinar today?
I'll sure try. So I'm Vice President of Quality over all of our quality and patient safety initiatives. I'm here with Scott, who is our Service Excellence Consultant. So he is very close to sort of the day-to-day world of how we manage patient experience. And I think I'm intrigued by this topic because these are very, very sick patients and family members that are often, also in crisis mode, and just wondering sort of what kind of engagement strategies for this particular topic. I mean, we are all over trying to prevent VAEs and DVTs, but I do think this population can be very challenging. Often there are just other issues that family members are overwhelmed with, and so I'm just be intrigued by what strategies in that kind of high stress area work. We have lots of evidence-based practices in this area that we are pretty good at preventing, and so it's really engaging nursing and physicians around that. But so I'm just curious as to what the patient-family engagement is around this particular topic. I'll just say we have a very high-end neuro population that often will spend days on vents, and so we're helping them over a stroke or something that has been very, very unanticipated for many of these patients. And the vent is definitely keeping them alive and trying to keep them positive. So does that make sense?
Makes sense to me. Karen, Mary, do it make sense to you guys?
It certainly does. Yeah, thank
Great.
you.
Great. All right. Sharon, thank you so much for sharing that. And I'll turn it now to Eunice at Alhambra. Eunice and Pia and your colleagues, would you be willing to just let us know who you are, your roles, and then your expectations and or at least hopes of what you would like to get from the webinar?
Hi, Boris. This is Pia from Alhambra Hospital. I'm here with Eunice and some of our nursing managers, our nurse educator, the head of our case management, risk manager. We have the patient relations coordinator. We're certainly looking forward to learning more, new ideas, especially from the perspective of the family. And hopefully we could use this to also prevent readmission. That's it. Thank you.
Okay. Anybody else from your group has anything else to add? You're talking about readmissions due to these particular topics of DVTs, Ps, and ventilator events?
Yes, that's right.
Mary, Karen, makes sense?
Absolutely.
Thank you. Thank you.
Awesome. Okay, well, if you have anything else to add, just chat it in or interrupt me, and we can add more things, more goals for you folks. But at this point, let's proceed. This is just a reminder of all the topics that we have covered. The two today are in kind of a beige arrow. These are aligned with Callahan Sprint that ends in September. With the high, lofty goals of reducing harm and readmissions. And our program has continued to be kind of aligned with those goals. And I just wanted to spend a couple of minutes talking about the capstone event. We've been communicating about it for a while now, and it is happening on September 16th, as you know. And we hope that all of you folks can attend. They will round out our learning on patient and family engagement as part of this program. It will also showcase the work that was done in hospitals that were participating in both Track 1 and Track 2. And this will be a joint event for both of these tracks. Registration is free, of course, but we do ask that each person who plans to attend please register. We'll be doing this at Sutter Health in Fairfield in the Bay Area, kind of outer Bay Area, and in their Green Valley Conference Center. You can see the full address on the slide, and we'll start in such a way, we'll start at 10 formally, start at 9 with breakfast and networking, but 10 o'clock formal start should be conducive to travel. I know for you guys from Southern California it may be a little more complicated to make it there, but we looked at flights, and for the most part, it might be possible to make this a one-day trip, albeit a long one. Acknowledging that, and we have on the member portal. We have the information about the capstone event at this link that you see on your screen. You can take a closer look at some of those. Provisions that we've put there. From Track 1, we are requiring that everybody, all the teams, make a presentation of their work under Engage. For you folks in Track 2, this presentation is optional, but we encourage you. And I know that Alhambra, you guys are part of both tracks, so I know we'll get your presentation as part of Track 1, and certainly would love to get Sharon and Scott and your colleagues, if you can attend, to not only attend but also share about your work with the the tool that you've presented on briefly in a previous webinar. I know that Karen is working with Barton Health on their presentation that is being continuously and actively shaped by their Family Advisory Council. And if you're presenting, we do need to receive your materials by September 2nd. And that's also here on the slide as well. And here, just some of the components of what you can find on the web, including the team presentation guide and PowerPoint template and travel reimbursement policy, which I want to cover now. We definitely want you to attend the capstone event and want to make it easy for you to do that. So we're covering some of your travel expenses, and you can read kind of the details on the slide. I'm not going to spend time going over that. Yes, go ahead, Scott.
So both events are happening on the same day, right? So we could go to one or the other. Is that I just want to make
No, it's actually, Scott, it's actually one event.
Okay.
It's one event, and no worries. And you can see if you go online, you'll see the draft agenda, and it will kind of be self-explanatory. We'll have Track 1 hospitals present on their work and the results in the morning. And then in the afternoon, we'll talk about sustainability, and we'll have some of the Track 2 hospitals, specifically Barton, I know is confirmed. We would love to get you guys to join in if you can, because we would like to cross-pollinate between those hospitals that are working on councils and some of you folks who have worked on these communication barriers that exist and overcoming them so that families can be more engaged in the actual process of safeguarding safety and quality. And those kind of go hand in hand, and that's why we are purposefully combining Track 1 and Track 2, kind of like what we did for the kickoff event. Anyway, so let me know if you can make it, and I'm not going to spend more time on this right now. If you have questions, let me know. The learning objectives for today are here: how to develop a process for creating family engagement tools for these particular issues, and then Karen and Mary will talk about co-production as a kind of a nice concept that fits in with this topic, and you can see some of those components there, and they'll talk more about it. Here's our team. Today we only have me, and Shweta is helping us out, and Karen and Mary, of course, are on the line as well. And with that, Karen, I'm going to turn it over if you'd like to begin. And again, we can keep this really interactive because we have a small audience today.
Okay, terrific. And I'm not sure how to advance this slide. Could you advance this one for me, Boris? Thank you. Thanks, everyone, for joining us here today. Mary and I are particularly excited, looking forward to this, because we had the most amazing experience in Vermont last month that we were quite excited to share with you. We were part of a group of about 90 people who gather annually now for about, this is in its 20th year, of hospital health professions educators summer symposium. It's a mouthful, so it's just HPESS. It's sponsored by the Dartmouth Institute, and people come from all over the country and Europe, actually, to focus on challenges in healthcare education. And we are challenged until our brains break to look at these issues from all kinds of sides in various challenging exercises to stimulate thinking. This year, the focus was on this term co-production. We always have this jargon in healthcare, don't we? But if you think about it very, very simply, it is the process of collaboration. And what does that look like? What does that feel like? How is it actually organized? What is the strategy behind it? All of the facets of that. But in very, very basic terms, I think Mary and I were most excited about it is because it helps us to help you accomplish what you want to do. It is, frankly, this notion, this mindset, headset, whatever you want to call it, an attitude of co-production is really the first very practical rung on the ladder for creating patient-centered care. And while the term is very simple, as we know, this thing called patient-centered care can be very complex. And so is, too, this notion of co-production. But Mary and I have winnowed it down to basically 4 different steps. And we're excited about it because we feel like we're able to offer a formula for you to follow to develop your own patient or your own family engagement tools to help you with the challenges that Sharon expressed, the very real crises that families face when their loved ones are on a ventilator, and how do we make them part of the care, part of the safety process, and best possible outcomes. And the same goes for people who are dealing with blood clots as well. So with that, I know it's kind of a big topic, but as I said, we're going to try to put it into bite sizes today with the hope that you will walk away with this sense of that you can do it, collaboratively. One of the things that we were broken up into teams, and we were asked, what's the vision? What's the vision here? Why are we here? And we just took a snapshot of the kind of the output of one team, and they said basically this is the vision. Welcome, and if you would, I'm going to read it very slowly, and please take it in, and I would love to hear from you how it makes you feel when you embrace this notion. And this is from the voice of the care providers to patients and families. Welcome to your system. Together we attend to structures, relationships, symbols, and politics to meet the needs of all. Journey in your system in the way that works best for you. Did anything happen as you tried that on for size?
Well, Karen, this is Mary, so I'm going to help you with an answer. But I just want to say hello to everyone and just start with an acknowledgement as we looked at the objectives for today, and we realized this last seminar or webinar as well. We're really not in this capacity, in this webinar, we're not here to teach you the fundamentals of clinical management of DVT or ventilator-associated pneumonia. We're not coming from that clinical perspective. That's your area of expertise and responsibility, and I think that's, you're on here to find some supplemental content, we hope, and we think that's what we can provide for you, so that what can families and care partners do, and what are the other steps where we can engage them in the big picture of prevention and management of complex care, particularly at the point of hopefully getting ready to get home, but even during the acute stay. So I wanted to assure you that we're not trying to ignore those very serious clinical challenges, and you spoke to that complex patient on a long-term vent and all of the conditions that they can encounter. Both Karen and I have had, family partners and loved ones in both of those situations, in terms of my uncle was on a vent before his death, and Karen's father experienced a vent episode. So, we've been there, done that, and I wish I hadn't felt so hopeless when it happened to me, and I think that's what we're trying to address is how do I become an active and engaged partner. But we're also, in response to this event, it is in its, I think, 23rd year this year, and I've gone 7 years. Only last year did we invite patient representatives. So you can see that all the nice people in the world, the concept of engaging others has come late to our environment, to our acute care, and into any care. And the whole notion of, redesigning care, when we use the terms patient-centered, in other words, it's our system. I think we've traditionally thought of it as, okay, welcome to my hospital. You're welcome to my unit, but I'm just going to set the hours of your visit. I'm going to restrict what you have access to for information, and I'm going to tell you how we're going to do things here. And that's been the tradition. I've been a hospital affiliated with hospitals, my whole nursing career. And, the whole idea that if we were to turn that upside down and change it and welcome to your system, we're all just a guest in this journey. And I think it just gives us an opportunity. There's some literature now. There's some models of concept. We don't want to spend all the time on that because we're really here about, tools that you can use to engage care partners and certainly to reduce readmissions. But it was striking. It was striking in that it's a kind of a cutting-edge conversation that was taking place with people who've been doing improvement for over 20, 30 years, and we're all still new to this conversation and in this way. And like I said, after all this aha of aren't we good people that care about improvement, it wasn't until last year, and that's why Karen was invited this year, where we expanded the number of patient and family representatives. So just to kind of put it into context, but also to let you know that, we're not going to tell you what heparin dose to use or what antibiotics are effective or what head of bed you need to keep your patient at. That's all available in other evidence-based literature about management of these complex illnesses. So we're just trying to bring you this other concept and then talk with you constructively about what are some of the tools for that engagement. So that was Mary.
Yeah, so there's the model. I don't know if you want to speak to this a little bit, Mary, or if you want to just go on to how the different steps are where we're hoping to help you bring it to life.
So I'm going to let you do that, Karen.
Okay, so fundamentally this concept of co-production is the opposite of the technical term navel gazing. And historically, if you don't remember anything else about this webinar, remember this, that the idea of co-production is that you don't have all the answers yourself. In fact, the best answers are found when you go outside of yourself. And that's really what came to my mind, Sharon, when you were talking about, in a very heartfelt way, your empathy for the patient's family members who are sitting bedside as they see their loved ones in dire crisis on event. The answers really lie with the conversations that you have with them and being transparent about your own anguish and about the system and your beliefs of what its strengths are and what its challenges are, and inviting others in to work with you for a solution, and really being very curious about the experience that others have of your staff's work and your systems and what works from their point of view and not. So if you get out of this and you say, okay, we are going to be outer directed, we're going to look at the world around us, the world that we serve, the world that we are allied with, for example, members of our community. We are citizens of this community, and so therefore everyone else is a colleague to us. If you go outside to get your own, to get others' perspectives and marry them with your own, there's a lot of power in that, and there's a lot of solutions, and probably, my guess is, a lot of aha moments. I guess the slides, how can I advance the slides for us?
See the little arrows on the bottom, the left and right arrow? You should click on either one and we'll advance.
Oh, sorry, yeah.
See that?
Okay. I'm sorry. I was seeing the slide on my screen. So this is the opposite of, like I said, if you don't remember anything else, visual to remember to go outside and to get outside of their worldview and to bring in the worldviews of others. So it's all about your, as I said, the people outside of your system, your colleagues, the other citizens in the areas that you serve, and that's everybody from the people that are parking the cars, they see the people that are leaving the hospital, to your people who are in marketing, who are communicating most often, to your pharmacists, clerical staff, and of course patients and families. But everyone has an experience. So you've seen this slide before, and that is in order to start those communications, obviously, to ask those questions, you need to start with a common vocabulary. And we, in fact, Mary, Boris, and I were having troubles with this for this webinar today because we see these terms all the time, but we know they simply wouldn't work. If you're going to pursue co-production, you need to have, very basic terms. So I wanted to ask all of you, what would you say if you're going to talk to the families, for example, of your patients on vents or who are at high risk for blood clot? What are the words that you would use instead of these? DVT, what comes to mind? We have a small group today, so just shout it out.
Blood clot.
Where?
Blood clots?
Yes.
Okay. And so for DVT, and you need to distinguish between, and what about PE? What would you say for that?
Well, I'd like to know that one. I experienced that recently with a family member, so.
Oh dear.
To give a simplified answer for us civilians, that'd be great.
Did you know what it meant before you got the news that your family member had a PE?
Somewhat of an idea, but it took some explanation. Many people just use the term pulmonary embolism, so it's severe. But what does it affect? How, things like that could be translated into layman terms. But they basically said this is a clot.
Oh, okay. So they clarified it at the time that they used the term?
Yeah.
Yeah, I think, what our point is, the acronyms that we're accustomed to really are meaningless to lay people, and even people in healthcare. You sometimes go, okay, so now what does that mean? So part of it is that translation into clear English. DVT, it's clots in the legs, comes from inactivity, common after surgery. This is why we're going to put leg pumps on. You can take it and you can do those extra steps, because then you're engaging the family member who can say, oh, why aren't the pumps on the legs? Or is it time to get up and do another walk? Or is, my loved one is accustomed to taking blood thinners, are they still on them? All of these good conversations that come from doing the translation. PE, not too sophisticated, but it's a clot that occurs in the lungs. But, that the lay person isn't using the word pulmonary, and the layperson doesn't use the word embolism. So our point is just that, these do take that extra step, and they become a teaching opportunity. And then obviously you can teach back at the time, and do you understand what's going on here? Can I, help explain this in a different way? So it's just a challenge for us because we get accustomed to our shortcuts.
And Mary, if I could just add, in my mind, this is an example of where we don't necessarily need to look for brief equivalency between our phrasing and the translation, kind of like with foreign languages, where sometimes you have a complex medical term that you're trying to present in a different language. You may need to speak 5 minutes about it. You may need to paint the picture of what it does rather than always have a ready word, either in a foreign language or in a language that a patient can understand or a family member can understand. And so we just need to be prepared to read the level of understanding and adjust our efforts to depict concepts.
Absolutely, and it may take a picture. Think of someone, drawing the lungs really quickly and showing where something is occurring and what it can affect. That's a really good point for us.
Well, and also the point of this slide really is that we just took a really quick snapshot of the terms that are most closely related to what we're doing today. But if the first stage of co-production, getting to solutions with all kinds of input from others, it's just getting to that common language, whether you're talking about, staffing or, locations of items in the hospital, just all of the different, medical vocabulary really has to drop away. The business vocabulary of healthcare has to drop away to become, much more approachable to everyone. The other part of that, so if number one is getting to a common language, number two is getting to a common mission of framing. This is our concern. We, for example, we want to, and I keep drawing on what Sharon said because she said it so eloquently, is we think we can do a better job together with our patients' families of dealing with the healthcare crisis and the potential outcomes for ventilator-dependent patients. So whatever you want to say, and Mary, you can probably, I know you can speak more to this as a great example from the Nursing Alliance for Quality Care. Mary, is she there?
Yeah, sorry, I was on mute.
Oh, yeah. Yeah, okay.
Yeah, no, I think we're just reiterating another set of mission statements from the Organization for Quality Care, run by nursing. That it's really appreciating the rights and including the mutuality of the. What's the goal? What's the joint goal that we're setting? People get well, they go home. If they don't get well, they stay comfortable. They're treated with respect. So I think we're ready.
Can I just make another quick comment? I'm being reminded as I am thinking about the concept of co-production, specifically around these really high stress, sick patients on ventilators and et cetera. It feels to me that we are not going to be successful unless we contextualize the entire experience of care from the beginning to the end and also in the community. And I think your co-production model really starts broadly and contextualizes all of that. In other words, if we expect to have great results only applying co-production concepts and look for tools once the patient is already on a ventilator and the family member is stressed to the max, we may not be as successful as if our entire care delivery is following that model of co-production.
Exactly, and it is big. I mean, and because we here in Engage are so focused on engagement for patient safety, that's why we're kind of trying to frame this as what can be done immediately, building on what we've done so far and where we can take it. So that's why framing the mission around quality and safety, and then further even the specific goals within that. Whereas, we might want to start with, blood clots and pneumonia, but there are all of these other things that we can come to solutions for with patients and families and others in the community around all of these other never events and, of course, readmission. So then after you can gather your team and understand and have the headset together that with a common language, that you start to look inside then, how do we as a team, our co-production team, how do we explore together the system, services, attitude, and bring an intense amount of curiosity to the task, which means suspending defensiveness, which isn't easy to do. But if everyone goes to the task bringing curiosity, defensiveness can drop away, because if the goal, as you frame the goal, that becomes the guidepost, if you will. And something that Mary and I really picked up is that we can all agree to be curious, to search for answers together, to be respectful, all of the things that were spelled out in the NAC mission statement, which is a really good template only just for example purposes. But underneath it all, we have sensitivities and biases that we do bring forward. And there is Mary, do you want to talk about that test that we all took that brought to the surface some of these things and what we experienced?
Yeah, it's actually a really well-known set of tests called implicit bias tests. It's out at Harvard, and it's actually, Boris, we could provide that link. And the reason it's important, we all come to our world, from the view where we come from. And we may not, I think in healthcare, particularly those of us that follow I'm a nurse, nursing code of ethics, I wouldn't say that, I think of people differently. I try to treat them equally. And that's just not true, because we are human and we have what we call implicit bias. So before we attended the conference, and we've done this with our students in nursing school at UC, we have them take the implicit bias test. And there's a whole range of them. You can take them for race. I took one for age. Because I guess I just turned 65 that week, and I thought, what are my attitudes about age? Because I don't want to get old, and I'm very critical of older drivers, I realized. And, it was what are my biases or economic questions. And it relates to a question I had yesterday from someone putting together a conference, and she said, well, how do you feel about, or how do you engage with people who are considered the non-compliant, the patients that just aren't willing to help themselves? And you start to think about that. We have our opinion. Does the person who smokes, who gets lung cancer, do we have a different judgment about them than the person who never smoked a day in their life who shows up with lung cancer? And do those biases in some way subtly affect how we work with people, what we assume their potential is, and what we might design in a co-production or a co-conversation. So anyway, it's an effective tool. Often it's relatively, I think it's recent that it's become so much a part of education. I do think it could be a greater part of our work world and enlighten all of us on how we can address issues that are just systematic and systemic in our society. So, thanks, Karen.
So you're touching on the issue of equity, which is critically important, and perhaps we haven't talked about it enough, and really we need to. And this whole implicit association test, I think those are excellent tests, and they're kind of like an ongoing research process at Harvard, where the more people take it, the more data they generate, and the more they understand about really what I think has been the hunch or the hypothesis that is being proven through this, that most of that, we used to think about bias as something being like really out in the open, really openly sort of bigoted and working with stereotypes and prejudices and so on. but these tests and this research really is proving that a great deal of our biases are below the level of consciousness, and the concept of micro inequities is becoming more and more prevalent, rather than sort of the blatant big inequities that we commonly think about.
Mm-hmm.
Absolutely.
So this idea of getting into the weeds with the co-producers really involves, as I said, curiosity, humility, lack of defensiveness, transparency, an understanding of where your own biases are, and your very best efforts to overcome them, of course. And then an analysis of the strengths of the organization in terms of, in this case, we're going to bring it back to preventing blood clots or preventing ventilator-associated pneumonia or any other hospital-acquired pneumonia for that matter. And where are we doing really, really well from all different kinds of perspectives? Where do we have weaknesses in what we're doing, or who's doing it? And what are the opportunities from our strengths, and what are the internal or external threats? This is just classic SWOT analysis, but it involves very transparent conversations, and always with the goal in mind of getting to solutions. So I created this slide just as a sort of a word cloud to really emphasize that when you can come together with more questions than answers, these answers and solutions in this model of co-production will emerge. And then finally, as a sort of a layer on all of this, so you come up with a bunch of solutions, and it's, you know, classic, hopefully, as a result, brainstorming will take place. And really, if this all feels very overwhelming to you, it's like, how are we going to get all these people together? How are we going to pick all these brains? How are we going to do all this? One shortcut would be, as a first step, is to take your quandaries and your concerns to your PFACs. Look at them as your eyes and ears to the outside world, and to bring them in, not just for, you know, policy meetings or for, you know, a walk around the hospital to look for ways that, you know, you could make them more comfortable, and not to minimize any of those things, not by any means, but to actually sit down with them in a comfortable setting and share your concerns, which means being transparent and asking for feedback, exercising that curiosity. But then in the end, when you're getting to solutions, one good way to think about getting to the sort of the to-dos, because as we've been talking about since last February, that when you give people something to do, they have ownership of their role and of their and of the results. They have also motivation. When you share facts with people in very simple terms, and you express that we are in this together and reasons why, and provide people with tools, I hate to use this word empower because I think it's kind of overused, but in fact you do empower them, and they become your allies to help advance the quality care that is everyone's goal. So this would be the fifth step, the final filter after you do the collaboration and the brainstorming that comes with co-production, and then apply this rubric. So here's an example. This checklist is in the ebook that all of you have. this is just a snapshot of one about how to prevent blood clots. And there's an angle tool that we created, 30-degree angle tool, that's meant for families to help them maintain top-of-mind awareness that the bed angle is important for people who are who are on ventilators. And this, I've actually had nurses who don't have the automatic beds in their hospitals tell us that it's hard for them to visualize what a 30-degree or 45-degree angle is. So this little handy tool, which is 1 penny worth of cardboard, is actually priceless. But what about, it's sort of in the spirit of co-production, what if you went to your suppliers, those people who are who are supplying your ventilator bundles? What if you brought them into the co-production collaboration and said, hey, put these in your bundles, we buy all of this from you, and when the ventilator is brought out, you can share this with patients and their family members. I mean, that might seem far-fetched, but it's just another way to think of who else is involved and can be engaged in helping us to reach this. And you know what? This is the wrong headline here. It's not blood clots. It's, I put it the angle slide on the wrong slide. I put the angle tool. It should be on the ventilator slide. So I'm sorry about that. And so here's going to a process now that we've talked about 1, 2, 3, 4. What would be your process to get to solutions for engaging families to prevent blood clots? This checklist is also in your e-guide to this Engage Track 2 seminar series. So this is simple facts for family members, including what are blood clots all about, what the risk factors are, and then how to help prevent them. How might you take this to the next level to create a tool using the steps, the co-production steps we've just outlined?
Or another way of asking that, Karen, I'd love to know from Alhambra or from anyone else on the call, how have you used the materials or instruct people, whose loved ones are perhaps in your units with the ventilator or, being treated postoperatively for DVT? Do you give them some patient and family information? Do you have any handouts or instructions? Because they can be your team partner, and that's the whole notion of this, that they can be eyes and ears for the staff, as well as the staff in facilitating safe care, consistently. So you may already have tools that you're using we'd love to hear about.
We have a small group. We invite everyone. We'd love to hear from you.
Karen, Mary, what comes to my mind is, just if I'm trying to put a head of a family member sitting next to somebody on a ventilator, I would want to, my first thought is I would want to know from you, the care provider, what are you guys doing? What's the team doing to prevent the blood clots? Before I can understand, I can begin to understand what my role is, I would really need to clearly understand what is it that you are doing. And I would need to be reassured, I guess, too, that you're doing everything under the sun, all the evidence-based things to make sure that this doesn't happen. And then adding to that piece of puzzle, my own role as a family member that can supplement that.
Absolutely. That's a great point for us. So we'd really need to explain, the plan of care for someone on a ventilator is this. And this is what we're trying to manage by turning, by head positioning, by administering certain medications, by suctioning, by doing mouth care. You go through the, this is what we will do, and the we then becomes part of the loved one's we as well, I mean, or the care partner, because there are parts of that while they may not be doing, they won't be suctioning, for example, they can be mindful of the head of the bed, like Karen said, the 30-degree angle tool, or, reminding somebody, oh, I don't think they've been turned in the last hour, just that kind of participatory conversation. But you're right, it does require that you have to, at the outset, this is how this care will be managed. These are the goals that we have. This is what we'll be doing. And then this is how we see you being engaged with what we're going to be doing. It's a very good point. It takes time.
The other thing that comes to mind is part of the process may need to be having a really good way of encouraging people to ask questions.
Mm-hmm.
And that's not easy to do, because people are often afraid to ask questions, afraid to look dumb, afraid, maybe not feeling like they're entitled to doing it. So what connects to me with this whole topic is the need to really address the imbalance of power maybe that exists in our healthcare currently, and unless we are able to somehow find some humility and address that imbalance of power, it's going to be hard for patients and families to feel entitled to asking questions, perhaps.
Well, absolutely, Boris, and that's where we started this whole series of workshops and webinars with, and that you have to build a relationship with the foundation. And this is what we will be doing with you, not to you or for you. And it is humility, and again, it represents an investment of time that can pay off huge dividends when, errors are prevented or harm is reduced or readmissions don't occur because someone has, been well informed and engaged right from the outset. But it isn't a natural way of the way work's been done. So it is new and very important.
And fundamentally, too, is and I don't know whether this comes up in medical school training or nursing school training, is the idea that medical information is to be shared among care providers, but not necessarily that care providers are in the business of educating patients and families. And I'll just give you a perfect example on the issue of blood clots. I was with my brother in the intensive care unit recently. He was being evaluated for a cardiac problem and actually a lung problem too. And he kept taking those compression boots off. They were just bugging him. And he just really wasn't having any of it. And the nurse would come in and just sort of silently adjust them and put them back on and say, you really need to wear these. And he was balking. And finally, I said to him, Ted, they're to help prevent you from getting a blood clot, which could go to your heart. And we're already concerned about a heart issue. And is that, and the light bulb went off, and he said, oh, of course. But I wish the nurse had delivered that. I was kind of waiting for her and hanging back for her to explain the why. But in any event, just instead of it being the care being task-oriented, if it could be more education-oriented, I think that would be hugely motivating for people to understand why. But those are just two pieces of those kinds of things could come up with discussions with your PFAC. Circling back to the great resources that you have, already developed.
I'm just curious, we have a few minutes left from you guys at Alhambra. How does this sound to you? What are your reactions when to this content from the practical standpoint in your hospital? You may be muted. Do we have Alhambra still on the line? Eunice or Ty or Pia, can you guys hear us? You're showing still as you're being on the line, but we can't hear. You're here. Okay, you were muted. You must have been muted. Do you guys have any feedback on this? We'd love to just hear from. How does this look to you?
Good.
Does it ring true? Does it ring doable, or does it ring really challenging?
It's challenging.
It's challenging because different nurses have different level of teaching abilities, and so that's our challenge in our hospital. It would be good kind of format, sure, that we can. I mean, right now what they're doing for education is mostly to the patient, but education we have something what we call TrueVent and Lexicon, where we can actually print out like information, like educational information for the patient. But it's not like a checklist of things. So maybe that's something we can look at and work on in terms of like teaching for the family or the patient. I think also the teaching, the challenge is the time. Now we're trying to be efficient and we charge patients in a timely manner, so it's the efficient.
Can you would you mind coming a little closer to the mic? I definitely don't want to miss what you're saying, but it's a little hard to hear.
Okay, we were talking about that it's challenging because we're trying to discharge our patients as soon as possible to prevent ER overcrowding. So when we do that, finding time to educate is one challenge.
Mm-hmm. Right. So I heard you guys say that something really important that I think Mary will resonate with. You've got nurses with different skill levels. So whereas one nurse may be extremely well adapted and skilled in communicating with patients and families in this way, their counterpart on the next shift may not be. So how do you create that sort of equalization of skill across the organization? I think I heard that as a concern. And
it's
I don't know,
a real concern.
It could be a whole separate webinar.
Yeah, thank you for bringing it up. There is it's practice, and I have to tell you, it's not natural. And it's scripting, and it's practicing the scripting, and having, not like reading, a book, but, having people develop the skills to take that explanation like Karen was waiting for with her brother. I'm putting these back on you. They're important because, we're trying to prevent a clot and we're already watching your heart. And it's like, maybe it had to come from Karen because it's the sister to brother. But, we all need to practice this because it's information. We are accustomed as a profession, and I'd say the other professions are equally guilty. Respiratory therapists talk respiratory to each other, and lab people talk lab, and physicians talk physician. And we have not taken the time to say, and this is what that means, because it does take time. But the more you do it, the faster it goes. And it is so important because you can reduce that readmission by alerting people to what they can continue to do when they go home and what they need to be looking for when they do go home, so that serious complications are picked up fast and not so serious things are handled at home earlier. But I think it's a challenge for us, and it could probably be the subject of the next research agenda. So.
Exactly. It's a big frontier to overcome. I am mindful of the time. would love to continue the dialogue, and hopefully we'll have a chance to do that perhaps at the capstone event. But Karen and Mary, do you have any parting words of wisdom before I close the webinar?
No, but we thank everyone for trying and knowing that this is new content or content that will require some revision of the way we do our work. We really applaud you for participating, and we look forward to partnering with you in the future.
Yeah.
All right, thank you.
Available by email or call if you would like to just chat about some ideas. Would love to help in any way we can.
Wonderful. Thank you so much. And before we sign off, let's just cover a few reminders. You can see on your screen the Survey Monkey at the very top for the evaluation. We would love to get your feedback. Your e-guide, there's a link to that contains all the tools that we're covering in the webinars. Our next webinar is on the 15th of September, and the topic will be family engagement from the perspective of the family, from the family's point of view. Our capstone event is on September 16th, and we are excited to seeing you all in good numbers. From Alhambra, certainly would love to have you guys join us and celebrate with us and learn with us. And as always, drop us a note to fill us in on how things are going. And to be continued, the work to be continued. And thank you so much for your time. Thank you to Mary and Karen for sharing their knowledge and experience. And see you in September. Have a wonderful day.
Thank you, Boris. Thank you, Karen. Thank you, Alhambra.
Bye-bye.
Bye-bye.
Bye. Thanks.
Thank you.